that my main brief today is looking at the safety of rural birthing and telling a lot of you what you already know. And if you do any literature research on this, the literature is quite convincing. I'm going to give you a snapshot, and I can't go into too much detail with the evidence, but we can have discussions later. So, as we've already alluded to, this is back to the future stuff. It's been happening for a long time. One of my anaesthetic colleagues, who I went through medical school with, who's working in New Zealand at the moment, said to me one day casually, you know, we don't accept bad outcomes anymore, John. We shouldn't be doing this in the bush. You know, that's why, you know, it used to happen, but bad things happened and no one cared, or people just accepted it because they were rural and they understood their risks. And when I actually showed him the evidence that I'm about to show you, his opinion on birthing and providing services in the bush completely changed. So there are lots of people in our medical community and our health community who have preconceived ideas that this is not safe. And this is why I'm giving you this talk today. In the context of the political goodwill, I think this is an important piece of the puzzle that we have to put right. There's been many studies that have supported the safety of rural birthing internationally over the last 20 years. And some of the good quality evidence that's come out has actually been from Australia. It's difficult to study, and a lot of it is observational, retrospective data, but perinatal data doesn't lie. The number of babies that die, you can't fudge that. The number of mums that get injured and hurt, you can't fudge that. So I know it's not randomised controlled trials and it's not prospective in a lot of these instances. However, I think that the historical data does speak for itself. This is one of the studies that I'm referencing here, and again, not going into too much detail. It was a study by Tracy et al., a very good Australian study looking at perinatal data across the country, collating that data and looking at safety in relation to size of birthing units and numbers of births that were delivered. It was a population-based study based on the National Perinatal Data Collection, and over 750,000 women took part in this research. And again, not going into too much detail, neonatal death was less likely in hospitals less than 2,000. That is a fact, based on that perinatal data, regardless of parity. This is a study from Atherton in Queensland. Again, a retrospective overview of their perinatal data over a long period of time. So with the Atherton study, in the years 1981 to 1990, averaging 330 births a year, their perinatal mortality was 5.2 per 1,000, and that was set against a background of a Queensland average of 13.5 in 1,000 at that time. That is a caesarean section rate of 13%. Between 1991 and 2000, the overall perinatal mortality was 5.3 in 1,000 with a caesarean section rate of 17.4. There were no maternal deaths during that 20 years of the study. There's other interesting research that I've gotten more into in preparing for this talk, and some of this was a surprise to me. When I came through the medical system and did my obstetric training, I never would have agreed with this based on the sort of information and the discussions that were had as part of that process. And when I see it, I believe it, and it is changing the way I think around rural obstetrics. So basically, the next few studies that I'm going to present show that international data is showing that it's actually as safe, equally as safe, to have models where you don't have access to caesarean section on site all the time. We do, I mean, certainly from the Rural Doctors Association perspective, we think that having access to operative delivery is important, and wherever possible should be sought after. However, I think this is important. This concept is important in the sustainability of rural maternity services, in that in the past, as soon as we've had a medical roster or midwifery roster where we couldn't cover 24/7, the unit has closed. If we agree to this premise that we can do this, then towns where, say, you don't have medical cover for a week or a couple of days, if we've got good communication, collaborative models in place and good pathways for where these patients go, then you know, we wouldn't necessarily have to knee-jerk close units, and I think that's what's happened in the past. So this is a study that looked at the outcomes of it was looking at the outcomes where you don't have access to caesarean section. 1,000 women in the study population
And out of that population, 64% were able to birth locally without operative facilities, 25% were transferred before labour, so good risk stratification, and 9.5% were transferred intrapartum. Again, this would be surprising to a lot of people, and their perinatal mortality was still lower than the national average in Canada. So, and they had a low caesarean section rate, as you would imagine. I've got another study that confirms this as well, but I'm not going to go into too much detail because of the interest of time. It's another Canadian study that compared 2 units of similar size in rural Canada, one which had Caesar capacity, one that didn't, and there was no difference in their perinatal mortality rate. They had a higher preterm labour rate in the town where they didn't have access to operative delivery, and clearly they had a higher rate of local birth. So I think the big difference here is that where you had access to operative and higher level obstetric capability, most of the women did birth locally. So if we have these models, we still have to accept that nearly half of the women are still going to have to travel, but in a risk stratified way, and I guess that's half the women that don't have to travel and have a better time of it. So this is a joint position paper put out by the Society of Obstetrics and Gynecology in Canada, which is a co-joint organisation, and it's basically was a literature search-based study and a position paper that brought together all the international literature around this issue and came up with recommendations and positions on this, and it included the Council of Canadian Associated Midwives and the Association of Perinatal and Women's Health Nurses and the GP College over there and their Rural Doctors Association as well, all put in, were involved in this process. And they came up with these sort of recommendations or policy positions based on that overview of the international literature in this space. Clearly they reiterated the access to surgical and operative services was desirable, and that there was evidence that good outcomes can be obtained even without access to surgical delivery. And there is clear evidence that women have better outcomes when they don't have that tyranny of distance and they don't have to travel, and that access to integrated perinatal care systems should be provided to all women and is part of the ongoing continuity of care. So that's my piece in a nutshell, and I hope it's helpful going forward in the discussion. I'm very happy to take questions and go forward with that. Cheers.